Bismillahirrahmanirrahim. Assalamu alaikum. Today I'm going to teach you chapter number 100 of Rooks, which is other acquired disorders of subcutaneous fat. Today we are going to cover the topic subcutaneous lipomatosis, which includes benign symmetrical lipomatosis. First of all, we are going to discuss the benign symmetrical lipomatosis. The definition is that the benign symmetrical lipomatosis is an uncommon condition characterized by multiple symmetrical unencapsulated fatty tissues deposits throughout the body. It is also known as Madelung disease, multiple symmetrical lipomatosis, Loenoy-Bensued adenolipomatosis. The introduction and general description in this, there is the same definition is given, which is characterized by multiple symmetrical unencapsulated fatty tissue deposits involving multiple areas of the body, particularly the neck, shoulder girdle, and the proximal upper and lower extremities. The incidence and prevalence is that there are less than 300 cases reported in the literature since its initial description, and the age of onset ranges from 30 to 60 years. However, a few pediatric cases are reported, and the mostly male to female ratio is 31 to 1. So, means it is more common in males. And the ethnicity is BSL has been linked to people of Mediterranean descent mostly, and the cases from non-Mediterranean ethnicities have been also described. The associated diseases are alcohol abuse, chronic hepatic disorders, possibly related to the underlying alcohol abuse, lipid abnormalities, arterial hypertension, chronic obstructive pulmonary disease, gynecomastia, hypothyroidism, peripheral neuropathy, diabetes, hyperuricemia, and myoclonic epilepsy, and red fiber syndrome. There are different percentages for each of these associated diseases. The most common one is most common is alcohol abuse 95.5%, smoking 77%, chronic hepatic disorders possibly related to the underlying alcohol abuse 59.1%, lipid abnormalities 41%, gynecomastia 27%, arterial hypertension 23%, COPD 23%, chronic and hypothyroidism 9%, with type 2 diabetes 4 to 5%. And the other associations are peripheral neuropathy, polyneuropathy, and autonomous dysfunctions. These are also the common findings among BSL patients. Compression symptoms affecting the respiratory and digestive tracts are thought to be directly due to the fatty masses in the anterior neck, and in one case series were the symptoms that in all cases occasioned the patient initial consultation. Now, the pathophysiology of this disease is, there are many theories on the pathogenesis of BSL, but a role for brown fat in BSL has garnered attention. Although grossly and histologically the accumulated adipose tissue in BSL is indistinguishable from mature fat, Ultrastructural analysis of adipose tissue deposits in BSL suggests that it resembles brown fat. Further support for the role of brown fat in BSL came from another study that demonstrated messenger RNA expression of brown adipose tissue specific uncoupling protein 1 in a lipoma of a patient with BSL, but not in the normal subcutaneous fat from the same patient. Brown fat hypertrophy has been proposed to result from functional sympathetic denervations or from alterations in the synthesis of intracellular cyclic adenosine monophosphate under noradrenergic stimulation. And the pathology is that lipomatous tissue in BSL consists of small adipocytes with no atypical features and a slight increase in vascular and fibrous elements. The lipomas are typically not encapsulated. And this is an important point, that the lipomas in BSL are typically not encapsulated and may infiltrate across the faciomuscular and neurovascular planes. Typically not encapsulated. In the genetics, the alterations in mitochondrial DNA have been demonstrated in BSL patients. Most reported BSL cases have been sporadic, although a very small number of familial cases exist for which autosomal recessive inheritance has been proposed. Now we come to the clinical presentation of BSL. The clinical presentation is the fatty masses develop most commonly on the neck, shoulder girdle, and the proximal upper and lower extremities. So you have to remember the sites: the neck, shoulder girdle, and proximal upper and lower extremities. Other less common locations include the retroauricular, submandibular areas, tongue, mammary region, abdomen, and perineum or scrotum. Although rare, laryngeal involvement resulting in a compromised airway has been described. The fatty deposits are slow growing and progressive over many years. In contrast to Dercum disease, the fatty growths in BSL are not tender or painful. You also have to remember this point, that in Dercum disease, the fatty growths in BSL are not tender or painful. In Dercum disease, the fatty growths are painful, while in BSL, these are not tender and not painful. The clinical variants of the BSL are the NZ's classification is most widely accepted, which has type 1 BSL and type 2 BSL. Type 1 and type 2. In type 1 BSL, the fatty deposits are mainly distributed around the neck, shoulders, supraclavicular fossa, and proximal regions of the upper extremities. While in type 2 BSL, more caudal regions of the body are involved. And the neck is unaffected. As a consequence, type 2 BSL patients may appear similar to obese patients. And the differential diagnosis of BSL are obesity, Dercum's disease, familial multiple lipomatosis, genetic syndromes presenting with multiple lipomas, such as Cowden syndrome, Benayan-Riley-Revelkeba syndrome, multiple endocrine neoplasia type 1, and Gardner syndrome. We have to differentiate these syndrome from BSL by other disease-specific clinical features. Some main features of Cowden syndrome are, as it is hematomatous syndrome, it includes macrocephaly, facial tracheolemomas, oral mucosal papillomas, dysplastic cerebellar gangliocytoma, thyroid CA, breast CA, fibrocystic changes, and lipomas and acral keratosis. So if these features will be present, we can differentiate BSL from Cowden syndrome. And in Benayan-Riley-Revelkeba syndrome, it is also mutation in P10 gene. There will be multiple lipomas, macrocephaly, hemangiomas, hematomatous intestinal polyposis, developmental delay, speckled pigmented macule on male genitalia. And in men 2A, there will be parathyroid hyperplasia, medullary thyroid CA, pheochromocytoma. So these are the differentiating features from the BSL. And in Gardner syndrome, it is also a variant of familial adenomatous polyposis. And in this, there are GI polyps, multiple osteomas, various skin and soft tissue tumors, and epidermoid inclusion cysts. So these are the differentiating features of other syndromes from BSL. Complications and comorbidities are mostly respiratory or digestive symptoms may develop if the lipomatosis from the anterior neck is significant enough to compress vital structures. There have been a few cases of head and neck cancer, especially squamous cell carcinomas, reported in patients with BSL. However, it is possible that this simply reflects the increased alcohol and tobacco consumption observed among BSL patients. Malignant transformation of lipoma into liposarcomas in BSL has been reported only twice. So the complications are respiratory and digestive symptoms may develop, and SCC of neck and head. And disease course and prognosis. The lipomatous masses are slow growing and progressive. There are few long-term follow-up data on BSL patients. In one study, however, in which 31 BSL patients were observed for up to 26 years, 3 of the 8 deaths observed were sudden and occurred in patients with autonomic neuropathy in the absence of coronary artery disease or history of cardiac diseases. Now we will come to the investigations. The diagnosis of BSL is based on clinical presentation and disease history. Chest radiographs may show abnormal symmetrical mass lesions due to accumulation of adipose tissue, and MRI is the best diagnostic tool in evaluation of the spread of adipose tissue, presence of tracheal compressions. So the best diagnostic tool you have to remember is MRI. Vascular topography within the fat mass and exclusion of synchronous malignant disease. And the management is, there is no established guideline for the management of BSL. A thorough clinical review, especially for respiratory symptoms, should be carried out at each visit to check for signs and compression or for the rare occurrence of malignant transformation. Medical treatments have been tried with generally poor results. The oral salbutamol. Medical treatments include oral salbutamol. It induces lipolysis by adrenergic stimulation and has been tested on BSL patients, but the results have been disappointing. And fibrates has been claimed to stop the growth or even reduce the volume of fatty masses in BSL patients. So the second medical treatment is fibrates. And among BSL patients who reported alcohol abuse, abstinence from the alcohol has had mixed results in preventing the progression or recurrence of the lesions after surgical treatment. General weight loss does not seem to be effective in reducing fatty masses. And in surgical procedures, open surgery, lipectomy, and liposuction with or without ultrasound assistance have been tried with varying success rates. Liposuction is less traumatic, has a lower complication rate, and produces less scarring than open surgery. However, because the fatty deposits are unencapsulated and diffusely infiltrate muscles and vessels without a clear plane for dissection, open surgery with direct observation of important structure is a safer approach in certain anatomical regions where liposuction may be too dangerous. So these both procedures have their own pros and cons, open surgery and lipectomy. Some authors advocate ultrasound-assisted liposuction, which can treat multiple areas in a single session and produces limited scarring. Regardless of the mode of surgical intervention, multiple procedures are often required, especially given the high rates of recurrence. In one study, BSL patients underwent an average of 3.3 open surgical procedures with a 51% recurrence rate. So means their recurrence rate is very high. Isolated lipoaspiration had a 95% recurrence rate in the same study. Recurrence rates vary by anatomical site, and you have to remember that the recurrence rates are highest following procedures on the arms and pectoral region. The average time taken for fat to reaccumulate after surgical intervention is approximately 21 months. Emergency intervention is needed when compression symptoms develop in rare cases where the fatty tissue deposits extend to the mediastinum and compress the trachea. A tracheostomy may be required. Now we will come to the second topic of this subcutaneous lipomatosis, which is Dercum disease. There are different names for this Dercum disease, as it is also known as adiposis dolorosa, morbus Dercum, adipocelgia, lipomatosis dolorosa, adipose tissue rheumatism, neurolipomatosis. We have to remember all these names because in paper these names can be given and can also be asked in viva. Dercum disease is a rare disease characterized by generalized overweight status or obesity and pronounced pain in the adipose tissue with or without the presence of lipomas. Dercum disease was first described in 1888. It is characterized by diffuse or localized pain involving adipose tissue, usually affecting those who are overweight or obese. Patients experience a number of other somatoform symptoms, and management of the condition is a challenge. Dercum disease affects postmenopausal women. A recent survey revealed that 86% of the patients develop their symptoms prior to the menopause. The sex-age Dercum disease is 5 to 30 times more common in women. So this is another differentiating feature from BSL, that it is most common in women while BSL was more common in males. There is no ethnic predilection of this disease. And there are some associated symptoms of this disease, while in BSL there were associated diseases. The various symptoms or diseases have been observed in these patients. None are consistently associated, but these include easy bruising, sleep disturbances, impaired memory, depression, difficulty concentrating, anxiety, rapid heartbeat, shortness of breath, diabetes, bloating, constipation, fatigue, weakness, and joint and muscle aches. The pathophysiology of this disease is also not exactly known. Many theories have been proposed, like that of the BSL. There are some theories regarding this disease also. A local defect in lipid metabolism has been considered. One study showed a difference in the formation of long-chain monounsaturated fatty acids between the painful adipose tissue and the unaffected adipose tissue in the same patient. And another study showed that the proportion of monounsaturated patients in fatty acid was significantly higher in Dercum disease patients than in the healthy controls. The painful adipose tissue from a Dercum disease subject was found to have a significantly lower conversion rate of glucose to neutral glycerides than non-painful adipose tissue from the same subject. In vitro analysis demonstrated that painful adipose tissue had reduced responsiveness to norepinephrine and lack of response to the anti-lipolytic effect of insulin compared with non-painful adipose tissue. And the roles of various inflammatory factors have also been investigated. It includes the higher levels of interleukin-13 and lower macrophage inflammatory protein 1 beta and fractalkine expression were seen in Dercum disease patients. So what is fructalkane? Fructalkane is a unique chemokine that is constitutively expressed by neurons. When fructalkane receptors are occupied, pain and resistance to opioid analgesia are promoted, which is in concordance with symptoms in Derkam disease. Other theories for pain in Derkam disease have included endocrine dysfunction as well as autonomic nervous dysfunction and stretching of and pressure on nerves by the growing fatty masses. So these are the cause of pain in Derkam disease, which we have to remember are endocrine dysfunction, autonomic nervous system dysfunction, and stretching and pressure of nerves by the growing pressure to nerves by the growing fatty masses. The pathology is when lipomas are present in Derkam disease, so they show the same typical histological features of lipoma without inflammation or vascular abnormalities. And the genetics, the cases mostly are sporadic, and autosomal dominant inheritance with variable expression has been reported, and HLA typing has not been revealing in this. A to G mutations at position A8344 of mitochondrial DNA, which is sometimes associated with familial multiple lipomas is not detected. Now, the presentation of Derkam disease, the main symptoms in Derkam disease, which are either abrupt or indolent onset of pain in adipose tissue. Lipomas may or may not be present in these patients who are typically obese. Patients have most commonly described the pain as burning or aching of the subcutaneous tissue, while some experience spontaneous paroxysmal attacks of pain. The most common locations of painful fat and lipomas are the extremities, trunk, pelvic area, and buttocks. The head and neck are spared. It is again a differentiating feature from the BSL that the head and neck are spared. Interestingly, patients experience more pain in the medial aspects of the involved extremities. Lipomas, when present, vary in size and firmness. While fatigue and psychiatric manifestations were initially included as cardinal symptoms of Derkam disease, subsequent literature has not been supported this claim. Certainly, not all patients with Derkam disease exhibit psychiatric symptoms. An association between BMI and anxiety and personality disorder has been noted. It has also been proposed that pain and obesity in Derkam disease may contribute to the psychiatric manifestations seen in some patients. Its clinical variants are important. Various classifications have been proposed over the years. In 2012, Hansen and colleagues proposed the following classification of clinical variants, which is number first is generalized diffuse form, widespread painful adipose tissue without clear lipomas. Second one is generalized nodular form. In this, there general pain in adipose tissue and intense pain in and around multiple lipomas. And number third is localized nodular form, pain in and around multiple lipomas, and the number fourth one is juxta-articular form. In this one, the pain in solitary deposits of excess fat, for example, at the medial aspect of the knee. The differential diagnosis of Derkam disease. Many diseases have similar symptoms to those of the Derkam disease. For the generalized form, fibromyalgia, lipoedema, panniculitis, and primary psychiatric disorders may be considered in the differentials. And other types of Derkam disease must be differentiated from conditions that may include solitary or multiple lipomas, as they may also sometimes be painful. These include multiple symmetrical lipomatosis, familial multiple lipomatosis, adipocytic tumors, neurofibromatosis type 1, MEN1, and MERV syndrome. MERV syndrome is a disease of mitochondria which is sometimes accompanied by painful lipoma. The complications and comorbidities of the Rooks disease is that it also may compress the visceral organs and it can become necrotic, or other comorbidities are mostly related to associated obesity or psychiatric morbidity. The disease course and prognosis of the disease is the natural progression of Rooks disease. It is very little known about that. Several cases reports suggest the pain gets worse over time. However, in one long-term study of patients with the condition, pain seemed to be relatively constant over the 5-year study period. The investigations for Rooks disease include diagnosis is based on clinical criteria after a thorough physical examination and exclusion of the differential diagnosis. So there are no laboratory markers for the condition, and also no inflammatory or autoimmune diseases, no test for these diseases. The management overall, there is little evidence on which to base treatment of Rooks disease. Management may be best achieved through a multidisciplinary approach involving multiple specialists, or pain in the setting has been observed to be refractory to traditional analgesics and NSAIDs. However, this experience has been challenged recently after a study from the pain in diminished in 89% of the patients when treated with NSAIDs and 97% when treated with narcotics. So, new studies according to the new studies, NSAIDs and narcotics are effective for pain treatment. And the other treatments are topical lidocaine with or without prilocaine, intralesional lidocaine, and IV lidocaine have also been tried. These were also with varying degrees of success. Pain relief from IV lidocaine infusion lasted from 10 hours to 12 months. Systemic steroids have been reported to improve pain in some while worsening it in other patients. A study showed that Rooks disease treated with intralesional steroids experienced dramatic improvement of pain in juxta-articular involvement. Meto alone and in combination with infliximab, pregabalin, or oxcarbazepine has also been used. 2 patients with concurrent Rooks disease and hepatitis C were successfully treated with interferon alpha 2b. A more recent small pilot study involving 10 patients showed that rapid cycling hypobaric pressure may decrease the pain. So new studies show that rapid cycling hypobaric pressure may also decrease the pain, and procedure-based approaches with suction-assisted liposuction and lipectomy have also been tried. Now, these were the treatment options for Rooks disease. Now we will come to our next topic, which is infiltrating lipomatosis of the face. Infiltrating lipomatosis of the face is a disorder where the unilateral overgrowth of unencapsulated benign and mature but invasive adipocytes involve the lower 2/3 of the face. It usually presents at birth. It is congenital infiltrating lipomatosis of the face. It may present in adolescence or early adulthood. It is associated with soft tissue and bony hypertrophy. So its associations are soft tissue and bony hypertrophy. And infiltrating lipomatosis of the face, patients have normal psychomotor development. The epidemiology in incidence and prevalence, there are approximately 50 cases reported in worldwide literature. The age for infiltrating lipomatosis of the face, although most cases present at birth, but adolescent and early adulthood presentations have also been reported. And there is no gender predilection, no racial predilection. And now we will come to the pathophysiology of this disease. The pathogenesis of ILF is unknown given the tissue overgrowth. ILF has been postulated to be part of the spectrum of overgrowth syndromes. P10 and RET mutations have been excluded, and no mutation has been found. ILF is generally considered to be the result of secondary somatic mutation at some point in early development. A study evaluating the expression of angiogenic and vasculogenic factors refuted a role for neovascularization in the pathogenesis of ILF. Pathology in the initial case description, Slavin et al. Described the histopathological features of ILF, which include infiltration of mature benign adipocytes into adjacent soft tissue with hypertrophy of the underlying skeleton. Infiltration of mature benign adipocytes into adjacent soft tissue with hypertrophy of the underlying skeleton. They also emphasized the absence of malignant characteristic and lipoblast, but found an increase in fibrous elements with focal fibrosis, affecting the nerve bundles and vessels with unifocally thickened muscular walls. The causative organism, cytomegalovirus inclusions within the secretory cells of the parotid gland are found in some cases. And the clinical presentation of this disease is that the patients with ILF present with unilateral facial swelling that is typically present at birth or in early childhood, although it may be delayed until early adult life. The facial swelling is due to the proliferation of unencapsulated benign and mature adipocytes, as well as associated soft tissue and bony hypertrophy. There's a wide range of clinical presentations depending on the extent of involvement of the underlying tissue. The lower two-thirds of the face is most commonly involved. So the most commonly involved site is the lower two-thirds of the face. Macroglossia and mucosal neuromas on the tongue and buccal mucosa have also been reported. And dental abnormalities, these are important for this dental abnormalities, which include abnormal tooth formation, root hypoplasia, and early eruption of deciduous and permanent teeth on the affected side. A cutaneous capillary blush usually occur after resection has also been reported. Now the differential diagnosis of this disease are other hematomatous or overgrowth syndrome like Proteus syndrome, vascular or lymphatic malformations and trauma, and as well as benign and malignant neoplasms of the bone or soft tissue, meant to be Benayan-Riley-Ruvalcaba syndrome and Cowden syndrome. Congenital hemifacial hyperplasia. It also shares some features with ILF, but this does not involve lipocytic infiltrations. And conditions which causes contralateral hypoplasia, like hemifacial microsomia and progressive hemifacial atrophy, Romberg syndrome, these should also be excluded. And other disorders of fat tissue infiltration, such as liposarcomas or lipoblastomatosis, may be ruled out based on the histological findings of these diseases. And the complications and comorbidities of this disease depend on the extent of involvement of the underlying soft tissue and bone, and the lipomatosis itself is benign. There will be cosmesis and resection of ILF risk injury to vital structures such as the facial nerve. So it is a major complication of this disease. The investigation is imaging with MRI, provides the best delineation, and the management of ILF involves resection of the tumor followed by reconstruction. The resection is almost always subtotal. Due to the infiltrative nature of the tumor into vital structures and carries a risk of injury to the facial nerve. On average, ILF patients undergo at least 3 surgical procedures with a recurrence rate of 62.5% with surgical resection alone. So its recurrence is also common with surgeries. The timing of surgery remains controversial, while earlier reports advocated early and wide local excision to prevent extensive lipomatous infiltration. Or recent literature favors delayed resection with temporizing measures such as liposuction, excision of mucosal neuromas, and surgery to the upper lip to restore facial symmetry. By delaying the resection until early adulthood, it is believed that the chances of facial nerve damage and the total number of debulking procedures required are diminished. And it has also been conjectured that growth hormone may play a role in recurrences, implying that mass reduction attempts prior to the end of adolescence may be more likely to fail. So there are two hypotheses that early excision or late excision, which one is better? Recently, a case of ILF demonstrating c-KIT and platelet-derived growth factor receptor oncogene expression was treated with imatinib after subtotal surgical resection, which showed 18 months follow-up. On the 18-month follow-up of the patient showed no disease progression. Now we will come to the next topic, encephalocraniocutaneous lipomatosis. It is a rare neurocutaneous syndrome characterized by profound mental retardation, early onset of seizures, unilateral temporofrontal lipomatosis, ipsilateral cerebral and leptomeningeal lipomatosis, cerebral malformation and calcification, and lipomas of the skull, eye, and heart. So it has features of both the cutaneous features as well as the features associated with CNS. The hallmark skin finding in this is nevus siloliparus, which we have to remember. The nevus siloliparus is basically a Greek word in which the silo means beard, means no hair. So there will be no hair at the site, and liparus mean lipid accumulation at that site. So by this, you will remember the nevus siloliparus, no hair and lipid accumulation at the site of this nevus. It is a fatty hematomatous malformation of the scalp. And this condition is typically present at birth or shortly after the birth. And the incidence and prevalence of this disease is also rare. There are only 60 cases reported in English literature, and the age is cutaneous and eye findings are usually present at or shortly after the birth, while neurological manifestations may present later on. There is no gender predilection for this disease and no racial or ethnic predilection. The pathophysiology of the disease is also unknown. Most tissues affected in ECCL are of neural crest origin. In addition, because all the CNS anomalies are caused by mesenchymal defect affecting tissues surrounding the brain or the vessels, and since no primary structure brain malformation is observed, it is postulated that a gene involved in vasculogenesis and the development of multiple mesenchymal tumors may be involved. So the pathology, the histopathology of nevus siloliparus shows focal dermal fibrosis with subcutaneous fat in the reticular dermis. There will be two things, focal dermal fibrosis and subcutaneous fat in the reticular dermis of the nevus siloliparus. And the clinical features, The clinical features will be of both the skin and the CNS and eye anomalies. Patients with ECCL present with wide spectrum of clinical manifestations. Nevus sialiparis of the scalp is the most common skin finding. And unilateral or bilateral subcutaneous fatty masses can be seen in the frontotemporal or zygomatic region and rarely seen outside the craniofacial region. Patchy or linear alopecia, which is typically non-scarring, can be seen. And it involves the lines of Blaschko. Or occasionally, scarring can be present. Fibromas, lipomas, and fibrolipomas present typically in ipsilateral skin. In ipsilateral skin tag-like cutaneous polyps on the eyelid or following a line from the outer canthus to the tragus. And less common cutaneous manifestations include irregular or disrupted eyebrows and cafeolemacules. Choristomas with or without other eye anomalies can be seen. And brain anomalies primarily involve the tissue surrounding the brain, including blood vessels. Intracranial lipomas are the most prominent feature of this disease. And other features include meningeal and meningovascular anomalies and spinal cord lipomas, which may be extensive. And the CNS findings are frequently confined to the same body site as the cutaneous lesions. The spectrum of the neurological manifestations of ECCL patients is broad, ranging from normal development to mental impairment of various degrees to intractable seizures. Less commonly, skeletal system involvement with jaw tumors. So what will be the skeletal system involvement? There will be jaw tumors or lytic bone lesions, and which can be progressive. These are the features of the ACCL, and the other feature, congenital heart malformations. In particular, aortic coarctation is seen in 10% of the ECCL patients. And the differential diagnoses include Proteus syndrome, oculoectodermal syndrome, oculocerebrocutaneous syndrome, and epidermal nevus syndrome. The complications of this disease depend on the extent of organ system involvement, and the investigations are biopsy of suspected nevus, or skin tags around the eyes, and ophthalmological examination is required to detect the associated ocular anomalies, and neuroimaging studies may characterize and assess the extent of CNS involvement. Neuroimaging studies, and since the fatty masses can involve the spinal cord, it is recommended that MRI of the spine should be performed. And ECG and echocardiogram for cardiac problems. The management is multidisciplinary care. Thank you. Today we have done the part B of chapter 100, acquired disorders of subcutaneous fat.